Hello everyone. We will be discussing the Spirochetes, Treponema, Leptospira, and Borrelia. Let us start with the genus Treponema, which would include the following human pathogenic treponemes: Treponema pallidum, subspecies pallidum, which causes syphilis; Treponema pallidum, subspecies endemicum, the causative agent of Begel; Treponema pallidum, subspecies pertenue, which causes yaws; and Treponema caraceum, the causative agent of pinta. There are also species that are not pathogenic to man, as for example Treponema denticola, which is found in the oral cavity. We're going to discuss in particular Treponema pallidum, subspecies pallidum. The spirochete is gram-negative, but because it stains poorly with aniline dyes, gram staining is not done to study it. It is very thin, with a width of 0.2 micrometer, which is at the limit of the resolving power of the bright field microscope. Because of this, the spirochete is viewed using immunofluorescence or after staining with silver stain or with the use of dark field microscopy. It is described to be long, slender, helically coiled, spiral, or corkscrew in shape. We mentioned earlier that it is gram-negative, and so it has an outer membrane, but exterior to this outer membrane is another membrane called an outer sheath or glycosaminoglycan coating. The spirochete is actively motile, and the flagella are called endoflagella or axial filaments, for the reason that they are found in the periplasm of the organism. And each flagellum would be starting from each end of the organism, winding around the body of the spirochete, extending to the midpoint. And from the other end, you also have flagella emanating from the ends of the organism, winding around it, and you now have the endoflagella meeting and overlapping with each other at the midpoint. The organism reproduces by transverse fission. However, we can see that the generation time is very long. It has a generation time of 30 hours. The organism is microaerophilic, and it is an obligate intracellular pathogen. The spirochete has not been cultured in vitro. It remains motile for 3 to 6 days at 25 degrees centigrade in proper suspending fluids and in the presence of reducing substances. We mentioned earlier that it is microaerophilic. It remains viable for at least 24 hours in whole blood or plasma stored at 4 degrees centigrade, and this is of potential importance in blood transfusions. The spirochete is hyaluronidase positive, which allows it to break down hyaluronic acid, allowing its spread in the different tissues. It also has outer membrane proteins which promote adherence to host cells, and a coating of fibronectin which protects it against phagocytosis. Tissue destruction primarily results from the host's immune response to the infection. It should be noted that the natural host is man. In the laboratory, the organism may be grown in rabbits. Because the spirochete is very thin and it is actively motile, it can penetrate intact mucous membranes and also broken skin. With the studies using rabbits, it was found that the infectious dose is from 4 to 8 spirochetes. The following are the modes of transmission, and the usual mode of transmission is through sexual contact. It can also be through contaminated needles, contaminated blood given during blood transfusion, or through congenital transmission. The following are the stages in syphilis. The primary syphilis is characterized by the presence of lesions called chancre and this is an ulcer with a hard base. The figures here show examples of the lesion, and it is described to be painless with a punch-out appearance, indurated with raised border and also red smooth base. It is said to have scanty serous secretions. The lesion is highly infectious. In 30% of the cases, the chancre can heal spontaneously without treatment in 3 to 6 weeks. The secondary syphilis occurs 2 to 24 weeks later, and red maculopapular rash can be found anywhere in the body. Lesions called condylomas or condyloma lata, which are described to be moist, pale papules, can occur in the anogenital region, in the axillae, in the mouth and other parts. As for example, we have these developing in the chest area and in the umbilical area. Just like the chancre, the condylomas are highly infectious. The patient may experience syphilitic meningitis, chorioretinitis, hepatitis, nephritis of the immune complex type, or periostitis, which would be the inflammation of the periosteum covering the bone. The secondary lesions subside spontaneously, but contagious lesions may recur within 3 to 5 years after infection. It is said not to be infectious thereafter. Tertiary syphilis is the tissue destructive phase, and it appears 10 to 25 years after the initial infection in up to 35% of the untreated patients. Lesions called gumas, which are granulomatous lesions, are found in the skin, as we see in the figures here, in the bones and in the liver. Degenerative changes occur primarily in the central nervous system, and cardiovascular lesions are also found. This is characterized to be having very rare treponemics, and the exaggerated tissue response is attributed to the hypersensitivity to the organisms. Please note that the patient may pass through the primary or secondary stage or both without any symptoms or signs, and yet they may develop the tertiary lesions later on. The organism can pass through the placenta and cause congenital syphilis. This may result in miscarriages, and the following are the different manifestations of congenital syphilis. These would include the interstitial keratitis, saddle nose that we see here, periostitis or inflammation of the periosteum covering the bones. It would also include central nervous system anomalies, or what is called the Hutchinson triad, comprised of deafness, blindness, notch peg-shaped teeth, and poor bone formation such as saber shin, bowing of the tibia, and the bulldog appearance of a deformed maxilla. Let us go to the diagnostic laboratory tests of the spirochetes. The specimens can comprise of tissue fluids from the early surface lesions, blood, or cerebrospinal fluids. We mentioned that the organism cannot be stained well with the gram stain, and for direct detection of the Treponema pallidum, dark field microscopy can be used, also immunofluorescence microscopy, or staining the organism first with silver stain and observing them under bright field microscopy. Another way would also be to detect using polymerase chain reaction. Serologic tests are very commonly used to diagnose the disease. They are comprised of two main groups. We have the non-treponemal tests and the treponemal tests. The non-treponemal tests are used for screening and to follow up the efficacy of treatment. These tests are non-treponemal in the sense that they do not detect antibodies against Treponema pallidum, but detect what you call reagin in blood, and cerebrospinal fluid. Free agent is a mixture of IgM and IgG autoantibodies. Why are they called autoantibodies? Because these are produced against lipids released from damaged mammalian cells and which appear on the cell surface of the treponins. The test is not very specific in the sense that it is also produced in leprosy, tuberculosis, chancroid, leptospirosis, so many other diseases, also after recent immunization and pregnancy. The antigen used here is a complex of cardiolipin, cholesterol, and lecithin. Cardiolipin is beef heart extract, and this would be the one reacting with the reagent. Cholesterol and lecithin are added to increase the sensitivity of the test. The following are the non-treponemal tests. First one here, Venereal Disease Research Laboratory, or the VDRL flocculation test, can also be used with the cerebrospinal fluid. The second one is the unheated serum reagent, or the USR flocculation test. Together with the VDRL, these would now require the microscopic examination to detect flocculation. Unlike the succeeding two, the rapid plasma reagent, or the RPR test, and the toluidine red unheated serum test, or TRUST. In the figure, it shows the results of the flocculation test using a kit for the RPR. We see here flocculation taking place, and these are observed macroscopically without the aid of a microscope. Another group of serologic tests is the treponemal tests. A treponemal test is used to confirm a positive result obtained using the non-treponemal test. It detects antibodies in the blood that are specific for the treponema pallidum. And of course, the antigen used would be treponema pallidum antigen. Examples are the following. We have the treponema pallidum particle agglutination, or the TPPA. Here, gelatin sensitized with the treponema pallidum antigens is made to react with serially diluted serum from the patient. This will allow the determination of the antibody titer against treponema pallidum. Another test is the treponema pallidum heme agglutination, or TPHA, and the microhemagglutination treponema pallidum, or the MHA-TP, both of which will be using sheep red blood cells sensitized with the treponema pallidum antigen. Another test is the fluorescent treponemal antibody absorbed, or the FTA-ABS. It's called absorbed because the patient's serum is first made to react with treponins other than treponema pallidum to remove nonspecific antibodies. The prepared serum is now made to react with the antigen from treponema pallidum, after which an antigen-antibody complex is produced, but which is not visible to the naked eye, nor under the microscope. And that is why an additional step is done wherein anti-human immunoglobulin, or antibodies produced in an animal that would be directed against the human antibodies, are made to react with the antigen-antibody complex formed. But this antibody, the second antibody, is conjugated with a fluorescent dye, like a fluorescein. After reaction, the anti-human immunoglobulins will be bound to the human immunoglobulin found in the patient's serum. And because it is conjugated to a fluorescent dye, its fluorescence can be observed under a fluorescence microscope. While a person with active or latent syphilis appears to be resistant to superinfection with treponema pallidum, it has been noted that various immune responses usually fail to eradicate the infection or to arrest its progression. If the early syphilis is treated adequately and the infection is eradicated, the individual again becomes fully susceptible. The treatment of choice is still penicillin G, and in most cases of syphilis other than early syphilis, ceftriaxone can also be used. Tetracycline or doxycycline is used for patients who are hypersensitive to penicillin G. Let us now go to another genus, Leptospira, and we're going to take up Leptospira interrogans. Leptospira interrogans is a tightly coiled, thin and flexible spirochete. One or both ends are often bent, forming a hook, and it is gram-negative. However, just like treponema, it is poorly stained with the aniline dye, so gram staining is not done with it. Instead, it is stained with silver stain. So we can look at this figure. We see that here both ends would have the hook, and they say it's called interrogans because it looks like a question mark. So this slide here, the organism was stained with silver stain. It is also best seen using the dark field microscope, and they would appear to be very delicate, such that they may appear to be only comprised of a chain of minute cocci. We have here the dark field microscopy. We have the bent hook at the ends, and we see that they appear to be like a chain of minute cocci. We know that they are spirochetes, but because they are very thin, this would be how they appear under the dark field microscope. They are also very actively motile, just like the treponemes that we have discussed earlier, Treponema pallidum. And also similar, they have periplasmic flagella, but this time there are only two axial periplasmic flagella anchored at opposite ends that extend the length of the bacterium. The motility is described to be spinning motility or a rapid back and forth movement. And just like the treponema that we have discussed, it has a delicate outer sheath. However, it is an obligate aerobe, not microaerophilic, unlike the treponema species. It derives the energy from the oxidation of long-chain fatty acids, cannot use amino acids or carbohydrates as major energy sources. This is very interesting to note. And the main source of nitrogen would be ammonium salts. The organism can survive for weeks in water, particularly at alkaline pH, and this has something to do with its transmission. Leptospira can be found in urine and blood of infected animals. Human-to-human transmission has not been documented because the organism is very thin and highly motile. Like the treponema that we have discussed, it can enter through breaks in the skin and intact mucous membranes, such as those found in the mouth, in the nose, and also we have the conjunctiva. Less commonly, it may be transmitted via ingestion, and the incubation period may be from 1 to 2 weeks. The organism can cause subclinical infection, mild influenza-like febrile illness, or even severe systemic disease. We have the wild disease or the icteric leptospirosis. The severe systemic disease can lead to renal and hepatic failure, extensive vasculitis, hemorrhage, myocarditis, meningitis, and even death. The organisms can be found in the blood and the cerebrospinal fluid in the first 10 days, and in the urine in the second or third week of disease up to 3 months. The box here shows the potential virulence factors of Leptospira. This would include hemolysins, sphingomyelinases, fibronectin binding protein for adhesin and invasion, lipopolysaccharide, and outer membrane proteins. Let us now go to the laboratory diagnosis. For microscopy, we have mentioned earlier that the Leptospira is a gram-negative spirochete. However, it does not stain well with the aniline dye, so gram stain is not used with it. The silver stain is used to stain the organism, but according to the reference Murray, it is not reliable in the detection of the Leptospira. Just like with the dark field microscopy, although we can view the organism using dark field microscopy, and this is usually used, it has also been reported to be insensitive. Microscopy is insensitive if you have very a small load of the organism in the specimen. And it is also capable of yielding non-specific findings in the presence of other spirochetes. For the culture, the specimens used would include blood, cerebrospinal fluid, and also urine. The culture media include Fletcher's, Swartz, EMJH or Ellinghausen, Baculo, Johnson-Harris, twin 80 albumin, and it has been noted that the addition of the anti-cancer drug 5-fluorouracil can prevent contamination by other bacteria without harming the leptospires. It is an obligatory aerobic organism, so it would require aerobic incubation at a temperature of 28 to 30 degrees centigrade. The generation time is shorter than that for Treponema. However, it's still very long, from 6 to 16 hours. And the incubation period then would be up to 8 weeks. However, usually after 1 to 2 weeks, the leptospires can produce a diffuse zone of growth near the top of the tube and a ring of growth at a level in the tube that would correspond to the level of the optimal oxygen tension for the organisms. Serologic tests would include the microscopic agglutination test or MAT. This is viewed using the dark field microscope. Here, the antigen used is comprised of pooled live leptospires of different serotypes, because Leptospira interrogans is comprised of different serotypes. And because it is using live antigen made to react with the serum of the patient to detect antibodies, this can be dangerous and only reference laboratories are allowed to use this. We also have the indirect ELISA. Leptospirosis is essentially an animal infection, and the principal sources of human infections include the rats, the mice, wild rodents, dogs, swine, and even cattle. The Leptospira is excreted in the urine both during the active illness and during the asymptomatic carrier state, where the organism can persist in the renal tubules. Leptospira can remain viable in water for several weeks. The different activities, drinking, swimming, bathing, food contamination, and we're familiar with what happens in the Philippines, wading in contaminated flooded areas, may lead to human infections. Persons most likely to come in contact with water contaminated by rats, such as the miners, sewer workers, farmers, and fishermen, run the greatest risk of infection. Doxycycline in dose of 200 milligrams orally once weekly during heavy exposure is effective for prophylaxis. Vaccines are also available for dogs to prevent the infection with Leptospira. So we have the distemper, hepatitis, leptospirosis vaccines. Treatments for mild leptospirosis include oral doxycycline, ampicillin, or amoxicillin. For moderate or severe leptospirosis, this would involve intravenous injection of penicillin, ampicillin, or ceftriaxone. We go to the last group of the spirochetes, the Borrelia group, and we'll be discussing Borrelia recurrentis and Borrelia burgdorferi. This is an interesting table showing us the diseases that we're going to take up, the reservoir, and the different vectors that are involved. Borrelia are gram-negative and larger than other spirochetes. They are microaerophilic and stain readily with bacteriologic dyes, also with dyes used to stain blood smears such as giemsa or right stain. Borrelia can be cultured in fluid media containing blood, serum, or tissue, but they rapidly lose their pathogenicity for animals when they are transferred repeatedly in vitro. In some ticks, but not in lice, the spirochetes are passed from generation to generation. There is what you call the trans-ovarian transfer. Interesting to note would be the antigenic structure of the organisms. They have a propensity to change their antigenic structure in the course of a single infection. They exhibit great antigenic variation. And in fatal cases, the spirochetes can be found in great numbers in the spleen, in the liver, kidneys, gastrointestinal tract, in the spinal fluid, and the brain of infected persons. One of the diseases caused by Borrelia species is relapsing fever, and there are two kinds. The first is the epidemic relapsing fever caused by Borrelia recurrentis, and it is transmitted by Pediculus humanus, human body louse. The only reservoir is man. The second type is endemic relapsing fever caused by Borrelia species, and there are different species associated with this. The species name is the same as the species name of the associated tick. Let us have, for example, the name of the soft tick is Ornithodoros, and this particular species, Borrelia hermsii, is transmitted by Ornithodoros hermsii. That is why it's called Borrelia hermsii. This is a zoonotic disease, and the animals that serve as reservoir hosts are rodents, small mammals, and soft ticks themselves. We have here the figure of Pediculus humanus and the soft tick Ornithodoros species. We have learned that the relapsing fever may be the tick-borne endemic type or the louse-borne epidemic relapsing fever. The incubation period varies from 3 to 10 days. Let us use this figure to follow our discussion. So the incubation period is approximately 3 to 10 days, after which there can be sudden onset with chills and an abrupt rise of temperature for 3 to 5 days. And during this febrile stage, the spirochetes abound in the blood. After this, fever subsides, leaving the patient weak but not ill. The afebrile period can last from 4 to 10 days. So, spirochetes are not found in the blood during this period. This can now be followed by the second attack, wherein you have again chills, fever, intense headache, and malaise, followed by a febrile stage, and the cycle is repeated. Now, it is said that antibodies against the spirochetes appear during the febrile stage, and the attack probably is terminated by the agglutinating and lyting effects of these antibodies. It is interesting to note, earlier we mentioned that Borrelia has the propensity for great genetic antigenic variations. So it is said that these antibodies may react and neutralize those with antigens that are specific to them, but may select out and leave to be viable the antigenically distinct variants, allowing these to multiply and cause the relapse. So there could be 3 to 10 recurrences, and generally of diminishing severity, associated with the presence of antibodies against several antigenic variants. So the several distinct antigenic varieties of the Borrelia may be isolated from just a single patient's sequential relapses. For the laboratory diagnosis, blood is taken from the patient during the febrile stage and prepared for examination under the microscope. Thick or thick blood smears are stained with Wright stain or Jameson stain, and these are now examined for the presence of large, loosely coiled spirochetes among the blood cells. The specimen can also be used to inoculate animals, and after 2 to 4 days, the blood from the white mice are stained and examined for the presence of the spirochetes. Treatment would include tetracyclines, erythromycin, and penicillin. Let's go to Lyme disease, and this is caused by 3 species of Borrelia: Borrelia burgdorferi, Borrelia afzeli, Borrelia garini. And these 3 species have been reported in Europe, but only burgdorferi has been reported in Northern America. Our discussion would be on Borrelia burgdorferi. Interesting to note that it has linear chromosome in contrast to most other prokaryotic cells that have covalently closed circular DNA. Now, this species is transmitted to humans by the bite of an Ixodes hard tick. So we have Ixodes capillaris here, and the characteristic skin lesion is known as erythema migrans, described as a bullseye rash. It can cause flu-like symptoms, and late manifestations often would involve arthralgia and arthritis, cardiac, and neurologic manifestations. The organism can be cultured in Barbour-Stoner-Kelly medium, or the BSK2, with rifampin, fosfomycin, and amphotericin B to prevent the growth of contaminants. It is incubated for 6 to 8 weeks. For diagnosis, we have the 2-stage serologic approach, including the screening, the EIA, enzyme immunoassay, or ELISA, or the indirect fluorescent antibody test. Confirmatory test is the immunoblast assay. For treatment, penicillin, doxycycline, cefuroxime, and parenteral ceftriaxone are used. The main animal reservoirs are mice and deer. The materials in this module were taken from the following references and also from some internet resources as indicated on the slides. I hope you learned a lot from this module, and have a nice day.